my pleasure to introduce Dr. Emily Putnam-Hornstein to talk about her work. I think this will be a pretty exciting presentation for many of you, especially those in course 2, but I think in course 1 as well. And I've had an opportunity to work with Emily over many, many years, and it's always exciting to hear about the research that she's doing. So, Emily?
Wow, now I better be good. You guys have already clapped. Really excited to be here. Thank you so much to John and Des and Carol and others for the invitation. And I'm expecting lots of good conversation and questions if this larger group is at all similar to this morning's group. So, okay, am I coming through okay? Yes, all right, and I may move around a little bit. What I'm gonna do is I'm gonna cover a lot of materials today. I told John I have more slides than I will be able to get through, but that was partly strategic because I figured if questions come up, I can jump ahead. But I think I've got something for everyone because those of you who are really interested in the data and methods, I will be kind of giving you a little bit of a peek behind the curtain in terms of how we went about coding and developing a predictive risk model. And then for those of you who are more on the clinical applied side, I will also be talking about some of the work that's gone into implementing a model in Allegheny County, validating it, and it is still a work in progress, but hopefully implementing it someday in California. So just by way of, whoops, hopefully I get. All right, Mary, I've broken something already. I can use the mouse. The mouse works fine. Okay. Cool. So just by way of background, for those of you who are not in this morning's class, I direct a project called the Children's Data Network, where we do a lot of work linking up Child Protective Service records with other administrative data sources. Most of our projects we are doing just from a research and evaluation standpoint, hopefully producing publications that a few folks read, and then trying to think strategically about how we can translate those for policymakers and others. But this project with predictive risk modeling is the first time that I have been involved in building a model and using data with the goal of actually then translating it and implementing it as a tool. And something that is used in real time by Child Protective Service workers. So this has definitely been something new for me. Just to kind of step back and make sure that we're all on the same page, my definition of predictive risk modeling, not necessarily everyone's definition, but the way that I'm kind of thinking about this is that it is an automated tool or model or process by which some type of score is generated from existing data. And it's built from what we're calling predictors or data that would feed into the model. And what we're doing is we're trying to predict some future outcome, and the score reflects the likelihood that that outcome will occur. Okay, and then we're thinking about predictive risk modeling. So we've got kind of predictive analytics where we're just trying to predict future events. Predictive risk modeling, we're talking about using those scores to think about stratifying our population so that we can be more strategic in delivering or deploying, hopefully, resources that will be preventative and protective in nature. So I really do think of this as something where, if used well and ethically and smartly, has the potential to help us move from one-size-fits-all responses to much more kind of thoughtful and intentional responses by our child protection system. Some of the kind of the background for the work that I'm going to talk about, the way that I think about our child protection system is that we've created a system where tragedies occur, And every single time the tragedy has occurred, our response has been to make the front door just a little bit larger. And a kind of case in point is thinking about Pennsylvania and the Sandusky case. And what was the state's response? The state's response was to massively increase and change definitions of mandatory reporting. Now, maybe that's a smart strategy, but what that means is that now the state is fielding that many more calls. And so as we've made this front door much, much bigger, we haven't necessarily thought strategically about the types of tools our frontline staff need to make thoughtful judgments and respond accordingly. And this is really kind of reinforced by some longitudinal data that has been crunched nationally, where we now know that over a third of American children will experience an investigation for abuse and neglect between birth and age 18. Like a third of American kids, like that, I mean, to me, that is just astonishing, especially when you consider that the rates of investigations are not going to be the same across all communities. So we've crunched this data in California, and we know that almost 1 in 2 African-American children in our state will experience an investigation for abuse and neglect between birth and age 18. Now, am I open to the possibility that a third of American children at some point experience conditions where we would like additional supports provided to their families? Sure. But I just cannot, we talked this morning a little bit about different operational definitions of abuse and neglect. There's just no way that I can imagine a country where a third of American children are so endangered by child safety concerns that they need to be subjected to an investigation. So those are the investigation numbers, and then the substantiation numbers. And I do fall in the camp. I'm not really sure what to make of substantiation, but if you do believe that it's a valid indicator, that's 1 in 8 U.S. children. And again, I find these numbers to be pretty crazy. So what is the context in child welfare? Well, what that means is that our hotlines are screening incredible volumes of calls for abuse and neglect. And some of those calls involve situations that are urgent, or perhaps not urgent, but chronic and serious. But many of those calls are probably either custody disputes or relatively low risk, where if we knew which were truly low risk, we would absolutely want to redefine our system to have more of a kind of a child protection arm, and then more of a community response, differential response arm. In terms of the predictive risk modeling work and how can that help, this is a quote from my colleague, Erin Dalton in Allegheny County, where, a little funny context on this, she and I were in Chicago presenting, and there were a bunch of academics, myself included, who felt the need to include a quote from some famous person to make a point. And Erin sits there and she's like, you know what? I'm gonna make a quote from myself. So she's like, you know what you guys all need to remember is that while you might be scared of predictive risk modeling, what's even scarier is how we are making those decisions right now. And she originally had the slide me 5 minutes ago, but I got her permission to use this. So the first thing I want to start with is I hope we have a chance to dive into it. I get it. Predictive risk modeling, I wish we could use some different language. It's also wrapped up with targeting and profiling. And we should be concerned because we're talking about using data that we know has bias in it. If we're talking about predictive risk modeling is something that we hope will fix our system, but we're using old data from a system we think was perhaps less than perfect, then isn't that a problem? But what I hope you will emerge today thinking about is kind of how are we making these decisions right now? And if we can show that on the margin, using data in this form helps us to produce kind of more standardized, more equitable, and more accurate decisions, then let's stop pretending as if it's a crystal ball or it's going to be perfect. It's not, but can it still be a useful tool, if nothing else, for thinking about resource allocation and how workers spend their time? So for those of you who have not seen the New York Times article, they provide a nice overview of the work that was implemented in Allegheny County. I will point out that the reporter from the New York Times clearly liked the work. There have been plenty of other reporters who have very valid critiques and did not like the work, and I think that's really important that we kind of surface and have those discussions. But what Allegheny County implemented a few years ago, and it's now been independently evaluated by a team of researchers from Stanford University, is they were struggling with what is not an uncommon problem, which is they were fielding lots of calls to their child abuse and neglect hotline. And they weren't using any kind of standardized tool for figuring out what got screened in or what got screened out. And what they were finding is they were screening out a lot of calls where a few months later, the family would get reported again. A few months later, the family would get reported again. A few months later, the family would get reported again. And maybe on that third or fourth call, that's when they would go out. And at that point, things had deteriorated to the point that they had to kind of make a removal. And they'd kind of look back and they'd say, gosh, like if we'd known when that first call came in that this family was on a trajectory for future system involvement, maybe we could have gone out sooner, connected them with services, and done something that would have helped to prevent this outcome. At the other extreme, what they were finding is that for those they were screening in, there were very pronounced racial disparities, and they weren't sure whether that was really valid. And so what they were looking to do was to harvest information from their integrated data warehouse, which includes health and human service data across a range of sectors. So they didn't just have child protection data. And they were looking for a way to kind of make it more easily digestible and usable by workers. So to be clear, all of the data that we used to develop this predictive risk model, this Allegheny family screening tool, was already available to workers. But what we had to trust was that workers were going in and systematically looking up information consistently. And then we had to make the assumption that, you know, John looks up one family's history, finds out that a year ago an older sibling was in foster care. Barb looks up another family's history, sees that a year ago they had a child in foster care. And we're having to kind of make the assumption that John and Barb place the same weight on that particular data element, which I think we have ample reason to believe is unlikely to be the case. So what Allegheny rolled out is an Allegheny family screening tool. What happens now is calls come into the child protection hotline. They record information about the allegation itself. While they are entering information about the victim child, other children in the home, perpetrators, moms, dads, what's happening is the algorithm is pulling in history that we have for all of those individuals. And at the end of the call, they are able to generate a risk score that is telling them the likelihood that this family will end up with a child placed in foster care within the next 2 years. Okay, and that is built on kind of historical data that tells us when we look at the patterns that are exhibited in this family's history, they look very similar to other families where this has been the rate and the likelihood at which children are placed. One of the things that I will talk more about is that the devil is always in the details. So you can have a great model that does nothing because it's not implemented well. You can also have a great model that does horrible things because it's implemented in an unethical or the wrong way in terms of the use case. I think Allegheny has been very smart and strategic. One of the decisions that they made right off the bat was they were concerned, especially as they were rolling this out and evaluating it, that workers who would go out to investigate would suffer from some kind of confirmation bias, that if they saw that a family was high risk, they would feel this need to kind of see things that were wrong in the house and make a removal decision. Or if they went out and they saw that the family was low risk, that they wouldn't necessarily do a full and comprehensive evaluation. So what Allegheny County decided to do was to use this just for that first screening decision. So the worker gets that score, they've made their own assessment, they then go in and talk with the supervisor about their recommendation to either screen it in or screen it out. But once that decision is made, the worker who goes out to investigate does not know the score. So at that point, we are relying on hopefully a well-trained clinical assessment of risk and safety and protective factors. So we're really just talking about at the time the call comes in, when we have variability in terms of the information that's communicated by the reporter, we have different levels of history, how do we start to use that data? Now, Allegheny County was unique in any number of respects, including having this data warehouse. And so as Allegheny's work was rolling out, a number of other jurisdictions were also exploring, are there similar applications that could potentially apply to our county or our state? And California was one of those. So what I'm gonna present here is kind of a case study in how we attempted to to build, test, and validate a predictive risk model using California data. Okay. So here's what we're doing with a predictive risk model. What we did is we decided to kind of run with that use case in Allegheny, which is, can we generate some type of risk score that will help us understand the different trajectories of families at the time that calls come into the hotline? So the first thing we had to do is we had to think about, what are we going to train this data model to predict? Okay, and this morning there is a discussion around different types of outcomes. So one of the things I really want to reinforce here is that these are all system outcomes. All right, so I do not have a true ground truth measure of child abuse and neglect that we can use to train this model. Instead, the way that we've thought about this is, if a risk model is intended to help stratify a population so we can think strategically about where we deploy resources and services, then in some ways, what we care about is less, are we measuring true child abuse and neglect, but rather, are we able to assess which of these kids are going to have chronic or future or deep end system involvement, because those are all things that from a system perspective, we would like to prevent, both because then there are real efficiencies to be realized, and hopefully children and families are also better. So what we did is we defined with a community stakeholder group 6 different system outcomes that we would try to model and predict. We decided to try to predict over a 24-month time horizon. Why? We're assuming that workers are probably pretty good at assessing kind of acute or urgent situations. You get a call, there's a child with a broken arm in the hospital, you're gonna go out and investigate. I'm not sure that a risk model is gonna tell you all that much. And at that point, you need someone who is able to kind of gather additional information and use their clinical judgment. What we're not great at doing is figuring out that long arc risk. And so what we really wanted to do is to try to figure out 24 months out what's happening within that time horizon. So we defined 6 different outcomes, trying to train a model to predict a referral within 24 months. So after this call comes in, will we get another referral? We defined kind of a chronic measure of future referrals or community concerns, 3 additional referrals within the next 24 months. We also decided to run with substantiation inconclusive, trying to predict those outcomes. And then we also tried to predict whether there would be case opening or a foster care placement. So these are all system outcomes, but they're all different versions of future system involvement that we could observe in our data and try to predict. We also, in terms of the predictors, we drew information from our SACWIS system, from our administrative child protection system. In California, we don't have an integrated data system. So that was actually one of the kind of the critical tests for our state was, well, we don't have all the rich data that Allegheny has, but we're a much larger state and we can look across all counties. And so what we did is we pulled out around 400 predictors from that administrative data. Now, I feel like we make predictive risk models super sexy and fancy, and yes, we use machine learning and whatnot, but I gotta tell you, like in some ways, the real lift, the real work is just in getting the data all set up. And that was a lot of work. What we had to do is we had to kind of pull in fields around victim demographics. So how old is the child's gender, things you would expect. We did include in the model, call comes in today, what is the allegation type? Is it a mandated reporter? We're pulling in all the history for that child, so any past referrals, whether they were screened in or out. We're also aggregating data up to the referral level. As you guys know, when calls come in, there are often multiple children and there are multiple allegations. So we're looking at the time of day, the day of week, is it a vacation history? We're looking at all of the other allegations that may exist for other kids on this referral, but not this child. And then we're pulling in data for all of the other individuals on that referral. Now, this is me being an academic using a quote, but I think it's a really good one, which is, prediction is very difficult, especially if it's about the future. So one of the things that I just want to kind of talk a little bit about is how we had to code up all this data. So we tested over 400 predictors that are just coming from our child welfare data. But basically what we were doing is we have a relational database. So we're identifying the individuals in a referral, and then through this relational database, we're pulling all of their history, and we're effectively dummy coding everything so that then the algorithm can kind of crawl through all of the data. There were some fields that we could not use, and I'll talk a little bit about that. But the key thing that I want to kind of reinforce that was really, really hard about this modeling was trying to make sure that we were not including any forward predictors. Okay, so when you guys think about different types of modeling, the most common we're thinking about explanatory modeling. We're trying to think about variables that we believe has some causal relationship to the outcome that we are studying. You need to kind of just switch that off. Like predictive risk modeling, that is not what we're trying to do. We are happy to take any piece of information that helps us to more accurately classify an individual based on the outcome that they either do or don't experience. So we're really not thinking about any of the predictors we're using within a kind of a causal framework. So we're really thinking about, on that third side, the process of applying a statistical model or data mining algorithm to data for the purpose of predicting new or future observations. So what does that mean? Well, that means that we had to be really, really careful. In most causal models, what do we need to confirm? We need to confirm that the variable we think is causal in nature precedes the outcome that we are looking at. Okay, so X must precede Y. But in building out a predictive risk model that would actually be implemented and used, what you also have to make sure is that X, that kind of predictor, that variable, does not just precede Y in time, but that you can actually observe it at the time you are trying to make a prediction. So I will give you an example. If we're using historical data and we're trying to predict accurately which children will end up in foster care, and we are looking at parents' history of abuse and neglect with other children, and we think that there is a boyfriend in the home who we have data for, and we include that in our model, we might think we can really accurately predict this child's outcome in terms of future foster care placement. But if we then discover that actually that boyfriend, his name is only entered into the system 2 weeks into the investigation when the worker discovers that mom is not a single parent, and we only then know his history of abusing another child, then when we're building the model, we might think that that's available at the time the call comes in, but it's really not. It's a forward-looking variable. Does that make sense to you guys in terms of, and so it's really hard because when you're training and building these models, you're using historical research data sets. And so one of the things that we had to do is we had to spend a ton of time teasing out timestamps to figure out exactly when different predictor fields were entered to confirm that if we are running the model at Hotline, all the data we think is available is actually available. Another key piece of this is that missingness can be really important. So in a lot of cases, like we're like, oh, we've got to throw out this observation because we have too much missing data. With our predictive risk modeling, what we're doing is we're actually hard coding missingness because that in and of itself can be quite informative. Okay, in terms of the modeling approach, what we did is we were able to extract around 3.7 million observations, and each observation you can think of as a row of data, and it reflects a referral that came in for a given child. So if there are 3 children on a referral, we will have 3 rows of data because that referral child combination will be unique. And we pulled data from 2010 to 2014. So we kind of pulled this historical data so that we could then try to train a model to predict out 2 years. In terms of building out this model, what we were doing is we set aside some records that did not become a part of our training or development set. And so we're training the algorithm to try to kind of move through the data and predict each of those 6 outcomes using one set of records. And then what the potential you have is that you fit a fabulous model for that one set of records, but that it actually cannot generalize to any data it hasn't seen because you've overfit it to be too specific to those observations. So then what we would do is we'd take that model and we would test or validate it on a set of records the model had never seen before to answer the very simple question, given these predictors that we're throwing in, how accurately can we classify each child based on the likelihood that they will experience each of those 6 outcomes? I'm actually going to skip over. If you guys want me to go back, I can talk a little bit about the data organization, but I won't. Instead, I'm going to kind of go into the modeling results and some of the ways that we went ahead and tried to kind of validate this. Before I do, any kind of burning questions where I've just totally glossed over something that's making no sense? Maria. So I'll talk a little bit more about that in the modeling results. Any other? Yes. No, sorry, what it means is that in California, we have a substantiation category, and then we have this inconclusive category. We find that they look very similar. Inconclusive means that a worker wasn't willing to say that there was no abuse and neglect, but they couldn't necessarily validate it. So we just kind of grouped those together to try to predict that. Okay, any other questions before I move on? Okay. All right, so modeling results. So the methodology we used is something called a balanced random forest methodology. So this gets a little bit to your question, Maria. So one of the things you have to keep in mind is that we had very imbalanced data, okay, for some of these outcomes. So for example, when we were trying to predict future foster care placement, I think statewide, about maybe 8 or 10% of kids experience a foster care placement within 2 years, which means that about 90% of our sample would be a 0 and only about 10% would be a 1. Well, what does that mean? Well, it means that we could build a model and just say, let's just classify everyone as not experiencing foster care placement, and our model you know, in theory would look pretty good because we'd get 90% of the people right. So what we had to do was kind of, when you have this imbalanced data, you have to kind of use different approaches to confirming that you've trained and validated your model to accurately predict kind of both the zeros and the ones. So what we did is we actually used a balanced random forest. We tested that against a few others. What does that mean? It means that when we were running our random forest models, we were training the model to draw random samples of the minority class, which would be the ones, and then random samples of the majority class, which would be the zeros, and we were kind of confirming the performance of the model on that test data set using that approach. I will also say that we started with just using general regression methods. Those worked pretty well too. So, you know, in some ways, you know, for the computer scientists, it's really fun to delve into all these different methods, and we definitely found some gains in accuracy, which I think are meaningful and matter. But the reality is you can actually do a lot with some pretty simple models too. This is a picture of kind of one of the trees. And I bring this up because one of the things that came up was, well, should you guys be using a regression model or some kind of machine learning method? Because you don't want this to be black box. And what I always respond with is, guess what? Most social workers don't really understand what an odds ratio or a regression method is either. And I'm not even most social workers, like most audiences don't, right? So I think the key is that we need to acknowledge that when we're using these more advanced methods to create any kind of risk stratification model or tool, they're going to be a little bit black box. But where we really want to kind of reinforce transparency is in openness about what's going into the model, openness as to what comes out of the model, how is it performing, and then openness as to the use case and how it's being used to support decision making. The models that we trained, we found that 2 of the outcomes we could predict more accurately than the others. Actually, 1 we could predict more accurately than the others, but we also, what we did is when considering those outcomes, we actually consulted with different community groups in terms of which of the outcomes they felt most comfortable with as a system indicator. And I don't think there's any consensus, and California hasn't made a decision, but we ended up, for illustrative purposes, building most of our use case around trying to predict either foster care placement or 3 or more additional referrals. That was because we could accurately or relatively accurately predict both of those outcomes. But it was also because what we heard was that people were more comfortable with those. First of all, with foster care placement, people said, you know what? It's not just a social worker. If a kid is placed in foster care, chances are lawyers and the courts are involved. And so they felt like there was just a little bit more structure and reliability to that decision than just a substantiation. They also felt like this is clearly something we would like to prevent if we can. So they liked that this would be something that is something where we would hopefully offer services to prevent it. With 3+ referrals, people didn't feel comfortable predicting just any future referral because there were real concerns around surveillance bias. But what they said is once you get to 3 additional referrals plus this one, which means 4 referrals total, either that is the community repeatedly telling you that, like, we're concerned about the child, or it's something that the agency needs to deal with because, my goodness, they're going to keep getting these calls and having to go out. So they also felt like that was something that was a little bit more solid and something that would ideally be preventable. We are getting AUCs for these models on the test data using a balanced random forest methodology in 3+ referrals at about a 0.80. And for foster care placement in the 90s, which I kind of almost don't believe. I think we may still have some forward-looking variables, but even when we strip out certain predictors and we really try to test for that, we're getting pretty good performance. But what does an AUC mean? It means that, like, we're doing much better than flipping a coin. How does that help a worker? And that's where most of our attention has really been focused on trying to think about what the use case and what the application is. Now, keep in mind, all this model is doing is it's trying to kind of predict whether or not, given what we know as of today, this child will end up in foster care or this child will end up with 3 or more additional referrals. And there are 2 ways the model can get it right, and there are 2 ways that the model can get it wrong. And how we trade off those types of errors really depends on the use case that we are thinking about. What we did in trying to translate this and think about how this might work in practice was we said, you know what, let's imagine that when calls come in, we take that underlying probability that's generated by this risk score, and we use it to bucket out kind of referrals into risk deciles, okay? Because from a workload standpoint, it's really nice to know, okay, I've got 10% here where the model thinks it's higher risk, 10% here where it's lower risk. So this allows us to use that underlying probability and assign every single child and every single referral a score of 1 to 10. The 10s, the model is telling us they think there's a high likelihood of future foster care placement, the 1s, the lowest likelihood. And then what we can do is we can actually look at how often that was true. And so this is built from the test data. And what we see is that for the kids the model flagged as a 10, 60% of them went on to be placed in foster care, either as a result of this referral or some future referral. Meanwhile, I want you to actually really focus on not just the 1s, but arguably the bottom 50% or more of referrals, where we see that fewer than 1 in 100 of those kids will go on to be placed in foster care. Okay, so what I would say when I look at this data is that the model appears to do a good job really flagging some very, very low risk kids and referrals, a good job flagging a very, very high risk subset. Not really sure what to make of the middle, but we do see somewhat of a graded relationship. When we look at 3 or more additional referrals, again, what we're doing is we're building from 10, 10, 10, 10, and then we're saying of the 10s, how many went on to experience the outcome. What we see is a more kind of graded picture, but we see that the model is clearly picking out some 10s where almost a third go on to have that chronic referral involvement, and the 1s where it's less than 0.1%. Now, I'll skip that. You might look at that data and say, okay, well, that's great. Maybe that's what workers know already. And so that was kind of our next step. We've built this model. We've been able to show we can build a fairly accurate model with just CPS data. We're pretty sure it's not including forward-looking variables. So then the question is, how, if at all, would this improve current practice? And so to look at that, what we did is we looked at kind of those 2 extremes, and we said, what happened with those cases, okay? And what we found is that for the kids the model flagged as a 10, or the referrals the model flagged as a 10, 18% were screened out without an investigation. Okay, now that's not that many, but it's still almost kind of 1 in 5. And at the other end, we were screening in 2/3 of those lowest risk referrals. So in both cases, we're like, well, maybe the worker saw something that the model didn't that would be helpful for us to know. So let's take a look at those 10s that were screened out, and let's also look at those 1 to 5s that were screened in to see what happened. So when we look at those high-risk screen outs, what we find is that half still got re-reported and ultimately ended up in foster care. So in my mind, it's kind of hard to argue that that was a good screen out. Maybe we could have done something. At the other end, what we see is that the model said they were low risk. We screened them in for an investigation. We went out to the house, and yet less than 1% ever ended up in foster care. Now, that's a harder group, because maybe it was still a good screen in, because maybe we had to. Maybe under the law there was something that was called in that we had to respond to. Or maybe the mere fact that we went out was an intervention itself. We connected the families to services. Mom kicked out an abusive boyfriend. Who knows, right? So there could have been something. But what I would say is that the literature would definitely lead me to question what kinds of service interventions we would reasonably think occurred with that group. And 2, even if something happened, did it need to be through an investigation? And I think that's an unanswered question, but certainly that's a lot of resources for some pretty low risk referrals. And again, an investigation is not without stigma. It is not, it places a burden on the family. then what we did is we said, okay, so clearly the model is telling us something a little bit different than just what the worker is looking at. Can we also compare it with how other tools that we are currently using? And I don't know, how many of you are from a state that uses structured decision making or SDM? Oh, not many. Okay. Well, just very, very quickly, SDM is a kind of a tool that was built. It's a checklist. And what it does, there's a few different SDM tools, but the risk assessment tool is used at the end of an investigation. And it is used to try to figure out which children are the most likely to be re-abused within 18 to 24 months. And so what we decided to do was to take the subset of kids from our test data who had a completed SDM risk tool to say, how did the tool classify them based on what the worker filled out? How would the model have classified them even upstream of that, right? And which proved to be more accurate. And so this was a little bit tricky because remember, we had risk deciles. That's what we've been using. What the risk model does, the SDM risk model, is it actually ends up bucketing out about 29% of kids to what they call a low risk group, 42 to a moderate, 21 to a high, and 7% to a very high risk. So what we decided to do is we use that underlying probability to mirror those distributions so that we could define a very high risk group according to the model and the probability, and then directly compare it to the very high risk group that was defined through the use of this SDM risk tool. And then we could follow those groups out to see what happened. And so here's what we found. A little bit going on here. So on the left-hand side where it says SDM risk levels, what you will see is that the size of the bar the width of the bar represents the number of kids in that group, because I didn't want us to lose sight that moderate is 42% of kids and very high risk is 7%. And the number at the top shows what percentage of those kids went on to be placed in foster care within 2 years. And on the right-hand side, what I'm showing you is the model. So if we look at those next to one another, you can see that the predictive risk model is able to identify more kids who actually end up placed in foster care than the very high risk group identified through the use of the SDM risk tool. And what you also see at the low end, remember the moderate risk group is 42%, and twice as many of those kids go on to be placed in foster care, even though they were called moderate risk, as those identified by the model. Now, we went through and did this using a bunch of different outcomes. We found it for 3+ referrals. We found it for substantiation. But the reality is that none of this should surprise us, because the SDM risk tool was built using about 16 items that a worker fills out. 8 of them come from administrative data, 4 of them are kind of subjective, and 4 of them rely on either a super diligent worker to gather the information or a family disclosing things around domestic violence and criminal justice involvement. The risk model, we don't have to rely on a worker to fill it out. We're just pulling data, which means that we can use hundreds of predictors and we can train the model locally on California data. And so in some ways, it shouldn't surprise us that one is kind of more accurate than the other. And it doesn't mean that predictive risk models should replace all sorts of tools. It just means that I think we should revisit when we're using clinical tools where we're gathering information that we can't find in administrative data. But if we're interested in a tool that purports to predict some future outcome, I think hands down, we're almost always going to get a better outcome and more accurate classifications if we just use data. One of the other things that we needed to do is we needed to think about this through an equity lens. Which is that we haven't built a crystal ball. The model is going to make errors in all sorts of different directions. But what we want to check is that as much as the model is getting it right or wrong in terms of the placement outcome and the accuracy of that classification, that it's not systematically making more errors for certain racial ethnic groups. So to look at this, we first looked at what the distribution of children would be based on this model. So remember that if you look at all children test set, we're kind of engineering the deciles. Right? So we should expect 10% of kids in each group. What we see is that we see slightly more Black or African American children in the higher risk groups. So it's about, instead of seeing 10%, we're seeing about 12 or 13% in deciles 9 and 10. We see more low risk kids who are Asian Pacific Islander, or more Asian Pacific Islander children who are distributed in the low risk groups. White and Latino or Hispanic look like the population overall, and Native American children skew a little bit more towards the higher risk group. But then when we look at the proportion of children who end up placed in each of those categories, so another way to talk about this is the calibration of the model by race ethnicity. And by the way, race ethnicity is not included as a predictor in this model. Doesn't mean that racial ethnic bias doesn't show up through other predictors or fields. But what we see is that as much as the model gets it right or wrong, we're seeing roughly comparable numbers of Black and white and Hispanic and Native American children classified as a 9 who go on to experience the outcome. So that's one way that we looked at this. What we also thought about is, are there ways that these tools can actually help us to surface and potentially be more intentional in course correcting where we think there may be human bias in our decision making? And so one of the things that we did is we actually looked at how many children are screened in by race and risk level. And so if you look at the low risk group, what you see is we looked at the bottom 50% and we said, let's look at all the Latino, Black, and white children who are called low risk by the model, and how many are we currently screening in for investigation. And what we see is that we are currently screening in about 67% of Hispanic children, low-risk Hispanic children, 65% of low-risk Black children, and only 59% of low-risk white children. Now, I can't tell you what the right screen-in rate is, but I would describe this as unwarranted variation because we know the likelihood of future system involvement is the same for all these groups, and yet we're systematically screening in more of our low-risk Black and Hispanic children than our low-risk white children. And at the other end, what you can see is a story of kind of under-screening in, arguably, for white children. So these are actually screen out rates, so we're screening out more of our high-risk white children than our highest risk Black and Hispanic kids. And so this has been helpful to at least thinking through ways that if we're to start to try to kind of shift the system a little bit in correcting for some of this, how do we start to use data and models like this to think about where there may be evidence of unwarranted variation? Okay, the final thing I'm just going to quickly mention is that we also really wanted to think about how we could externally validate this predictive risk model. So you guys remember system outcomes, okay? And I think I gave you a reasonable justification as to why we would try to predict system outcomes. But if our system is totally out of whack and we're predicting, say, future foster care placement, but we've systematically been placing all the wrong kids, then what tools like this could inadvertently do is actually focus our attention in all the wrong places. So what we tried to think about are what are some external outcomes that are not child welfare system specific that might tell us whether our model is sensitive to kids who are objectively at high risk. And so what we did is we actually, sorry for the circles on this, we looked at all of the kids who experienced a near fatality due to abuse and neglect, and we linked our records to vital death records, and we looked at all kids who died from an abuse neglect related injury. Okay, there weren't a ton of them, but there were about 394 kids. And what we then did is we looked at the risk scores that would have been generated had this model been in place prior to the near fatality or fatality event. And we did this at the event level instead of the child level, so that's why this doesn't look perfectly smooth. But remember, 10%, 10%, 10%, 10%. Right-hand side, what you are seeing is the distribution of scores for the subset of kids who experienced a near fatality or a fatality. Now, that doesn't mean that that percentage of kids who were scored a 10 went on to experience that event, very rare event, But what it does mean is that of the kids who died or had a near fatality, 59% of them would have been flagged by the model as a 10 prior to that event. Another 19% would have been flagged as a 9. So if we had some kind of more enhanced clinical protocol or service delivery system for our 9s and 10s, we in theory would have reached with some service 78% of the kids who experienced those events. Could they have been prevented? I don't know, but it at least tells us that we would be getting to the right group of kids. And if you look at the low end, yes, there will be children who die with very, very low risk scores, but we have kind of an empirical basis for saying the death rates there are quite low. So I'm going to just stop there. I do have some additional slides if questions come up, but John, do I have time for a few, or Mary, do you have time for a few more questions? Or a few questions, yes. Oh, thank you. See, aren't you guys glad I talk fast?
So I'm really interested in the piece that you spoke about regarding equity checks.
Mm-hmm.
And you mentioned running them for race and ethnicity. I'm wondering if you did equity checks for other variables like socioeconomic status, rurality versus urbanicity, location, child age at the time, or if those were included separately as predictors and you didn't really look at the distributions.
Yeah, so what we did do is we thought about including zip code and kind of geographic variables, and actually based on community feedback decided not to, because it kind of felt like the whole idea is that we're using person level data. We don't want to increase someone's risk score or decrease someone's risk score just based on the neighborhood they happen to live in. So we excluded that. We have done kind of a crosswalk of all of the other predictors that are in the model with race ethnicity to see whether there are any that really jump out as being skewed. And I think there's more work to be done, but we haven't necessarily seen that. I think one of the things to keep in mind is that Allegheny actually had to wrestle with this a bit more because they had all of that cross-program, cross-system data. So they had to wrestle with, how do we think about including criminal justice history if we think that there is real bias in terms of who will have an arrest history, because we know that African-American communities are much more likely to have but we didn't have that in our data. So the data that we're including, again, is, it's kind of the least sexy model ever. It's kind of simple counts of past reports and past placements and past encounters and histories. It's just that we've never been able to kind of pull it together and synthesize it in that way. So I don't want to say that we don't have a problem and we should constantly be checking it, but we haven't identified as of yet any huge kind of predictors where it just feels really uncomfortable. One of the other things we've done is we've shared the predictor list with, for example, I presented this several times to the LA Eliminating Racial Disparity and Disproportionality group. And I've given them the list of predictors. I'm like, let us know if there are things where like this just feels, even if it doesn't show up in the data, it just feels like something that shouldn't be in one of these models. So that's the other way that we're approaching it from a curation standpoint. Yeah. That's probably a longer conversation. I thought it was a very natural thing to kind of do and compare, but never underestimate the resistance from an existing vendor that has a tool out there in 25 plus states. The reality is that I think that if this were implemented, it would be silly for California to continue to implement the risk tool. I think the safety tool is something totally different. It's not an actuarial model. It's not trying to predict outcomes. I think the SDM hotline tool is incredibly valuable. So that's where it's not, I think it's more just thinking about what different types of tools may be needed. And my strong suspicion is that the field will move away from paper and pen risk assessment tools and will come up with better paper and pen tools for other purposes. Yeah. Oh, did you have your hand up before? Yeah.
I did. What do racial justice advocates have to say about this?
I don't know. And I don't know because we haven't I don't feel like there's one single answer. I mean, I guess the reality is that in criminal justice, I think the field has made some real missteps in how they've talked about and explored some of these risk tools, including with vendors where they were black box, where they didn't kind of adopt an equity lens in thinking about the model's performance. And that's kind of caused everyone to be like, oh my gosh, these are all bad. What I would say is that kind of one of the most consistent answers I've gotten when I've walked through these slides, or slides from Allegheny or slides from another jurisdiction, is they're like, this makes sense. I can see how this could be helpful. I could even imagine how this could help guard against some of the racial bias that we think operates in human decision makers. But because there is so much mistrust of the system overall, it still scares the hell out of them that they would be allowing a public government agency to use something like this, because they don't trust that there will be the accountability and transparency in its use. So.
Because it's just for that initial screening decision.
It's for the initial screening decision. Race, ethnicity is not in there, but there are other fields that do kind of suffer from bias, no doubt. There's, I think, an ongoing process in terms of assessing that and revisiting it. I will say the findings from the Allegheny evaluation, findings are not earth-shattering, but still some significant findings, given that this was a field evaluation with lots of kind of spits and starts as it went. One of the findings was that the tool appeared to increase the accuracy of screening decisions. And in that, what it meant is that for the children who were being screened in, remember, the worker goes out not knowing what the score is, and they found that more of the screened in referrals had open cases resulting, which means that you can argue an investigator saw something where they're like, there should be services. There was also a modest but statistically significant decline in racial disparities, which I think also left people feeling a little bit more like we should be cautious and careful with these tools, but they can actually work in that direction as well. The reduction in racial disparity actually emerged from slightly reduced rates of screening in African-American children in the county, and slightly increased rates of case openings for white children. So it kind of, in some ways, that picture I showed you, it appears that this may have actually been playing out in Allegheny as well, but there's more to kind of follow up on. Yeah, John.
So I have a technical question, maybe non-technical. That is, did you test comparative accuracy and did it make any difference? 18 months, 12 months, in terms of the accuracy?
So, we played around with that a little bit early on. We weren't finding that it was hugely different, but I don't remember the numbers off the top of my head. We ultimately ran with 24 months because we figured that would probably be the hardest to predict, because the most time will have passed. And we've just been waiting for, if the state were to implement, they might revisit. They might say, we don't want to predict 24 months out, which means we would dive back into the data. I will say, though, that I was at a presentation that New York City gave the other day, where they've also been working on some predictive risk modeling work. And I remember the lead analyst there said they had done some work, 6, 12, 18, 24 months. They'd done some of that comparative work, and they ultimately had landed on 24 months as the right kind of time point. And so I was like, okay, sweet, maybe that means we're using the right one, but I wouldn't say that with confidence based on California yet.
The second question is the one of implementation. So how do you use the information? I know in a lot of other risk modeling frameworks, there is a great deal of attention to how the information is actually used in decision-making processes. So you describe what's going on. The types of additional supports that are provided, and then the question is, what is the prevention might actually prevent foster care placement in 24 months? Given that we've got to sort of potentially think about a very chronic situation.
Well, I think that is the million-dollar question, and one that these models will only prove useful if we actually have the services needed to prevent the outcome that we have predicted. Otherwise, arguably, all we're doing is kind of predicting something and potentially differentially surveilling certain populations. So I think there's a lot more work done there. I will say from an implementation and a use case standpoint, Allegheny, it's been very, very focused on the hotline. One of the things just anecdotally that I heard from hotline workers that I was like, I like this, is that what happens is if they have made a determination, they think they need to investigate, they heard something on the call, and then they see a high risk score, they're like, okay, we've got kind of consistency there. So maybe the high risk score doesn't matter that much. But when they have assessed something as kind of perhaps not being all that significant, and then they see a high risk score pop up, what I was told is they know they can't go into their supervisor with those two discrepant pieces of information without delving into the data to have a justification as to why the model is saying high likelihood of future system involvement versus what I've heard on the call. And so I think what I was reading between the lines, it felt like there was a more thoughtful approach to then interacting with the data to either justify in the eyes of, or for the conversation with the supervisor, the decision they were making, or not. And likewise, if they think something's high risk and it's low risk, what they're doing is they're going into the data to make sure that the model hasn't missed something because they're duplicates. So I heard something about kind of that supervision conversation. I actually had a worker say, I still don't know if I really like this, but I at least feel like I'm like having richer conversations with my supervisor where instead of just kind of, loosely talking about the data, there's some framing for it. In Douglas County, Colorado, they have implemented a predictive risk model. The way that they are using it is they are not using it for the screen in or screen out decision, but they have red teams that meet for the kind of the non-immediate referrals. And so they have a randomized trial where half of the red teams will be presented with a risk score and half will not. And then the idea is how does that affect some of the kind of the team decision about what happens from there on out? That's still ongoing. And the use case that I've really been eager to see implemented, particularly in California. In California, we screen in so many referrals, but I don't think people are really comfortable saying we're going to use a risk score to not screen things in. So I don't think that's going to happen. But when I look at the data, what I see is I see a situation where we have a really, really high risk group. And we also have some really, really low risk kids. And I would love to see some kind of enhanced supervision protocol around the TENS so that once we've screened it in, if I'm a supervisor overseeing an investigation, I've been alerted to the fact that I have a very complex investigation taking place right now. And maybe I handpick another investigator with more experience to go out, or maybe I just meet more frequently with that kind of caseworker to make sure everything is covered. Or maybe as I'm about to close that investigation, that is the case where I sit down and I actually read from start to finish everything and I make sure the SDM risk tool has been completed properly and I go through everything. And then for the low risk group, I'd like to start seeing it used for racial equity purposes, which is that we're actually just creating a flag for supervisors. Hey, just so you know, this is a kind of a low risk child who's being screened in. Let's take a close look and make sure that the allegation itself rises to the level of investigation, because there's not enough history there to suggest that we should be screening this in. And I actually think that that could help to correct for some of the disparities that have huge reverberations further into the system. Yeah.
Obviously, your data that you're training your model on is disproportionately black and brown children. So I'm curious if there's any way that you're accidentally describing black and brown children instead of describing high risk? And then I know that then you're focusing on these 10s rather than the middle ground, but if you're looking at an outcome like 3+ referrals, which could be a very biased, because that's a human decision to refer, so it could be racially motivated in some way. I'm just thinking through it.
Yeah, so one of the things that we played around with is we said, let's try building race-specific models, because let's imagine that we think the data is the least biased for, say, Asian or white children. If we trained the model to predict outcomes for that group and then applied it to our African American and Latino children, would we see differences? And so we have played around with that. Nothing kind of surfaced that suggested that we are or would be picking up dramatically different groups of children. But I think there are a few different ways that you can tackle this. And I think that one thing that's really important to keep in mind is that in some ways, yes, there are empirical answers that can be generated through these models, but I'm a strong believer in a lot of this needs to be driven by kind of what the community is comfortable with, what the state or county stakeholder is looking for. And so I feel badly that I think we've only scratched the surface with some of this, but to be honest, we kind of have taken it as far as we feel like we could take it until we're told this is actually what we think we'd like to do, and then we can start to dive back in a bit more. And I would agree with you with the 3+ referrals, but that is where some of the sensitivity analyses with the near fatality and fatality data, I think, are compelling. I totally forgot to show you a slide. I stopped myself too soon that I think is also compelling. So remember, these are near fatalities and fatalities, but we did say to ourselves, maybe we're just picking up something around kind of other aspects of the environment that would make all of our high-risk kids more likely to experience deaths. And so we tried to come up with a death type that we thought would be least related to, say, social determinants of health, and we chose cancer. And so these are kids who died of cancer and had at least one prior referral. And what you see is that their distribution across risk levels is almost exactly what you would expect in terms of risk deciles. And so what that tells me is that whether it's 3+ referrals or foster care placement, like we are doing, like that is somewhat connected to a more objective form of harm. And we have done those breakouts by race ethnicity to make sure that there wasn't a vastly different picture for Black versus white versus Hispanic children. Any other questions? I know I'm a little bit over time. Okay, well, thank you guys so much. I'm always happy to talk this stuff, so.